I'm Mike Gibson, and this is TCT Crossfire. Today on Crossfire, we have Dr. Khalil Fattouch. Welcome, Khalil, and Dr. Michael Mack. Today, we're talking about or debating repair versus replacement for functional or secondary MR. Dr. Fattouch, you're taking up the point of view that we should always repair.
Yeah. Many thanks for this invitation and for your question. So I think that mitral valve repair is still a best surgical option in mitral valve surgery. So it's very, very important in secondary mitral valve regurgitation to avoid valve replacement, because we must sustain the continuity between the valve and the left ventricular, and especially in poor left ventricular functions. So if we look to the last randomized trial become from Acker and Koecker from the CTS networks, we see that mitral valve restrictive annuloplasty is enough to treat mitral valve regurgitation in more than 70% of patients. And it's fail only for the 30% of patients. So I think that we must focus our investigation to individualize better the patient, to avoid the bias in patient selection, and to improve the repair result in these 30% of patients.
And Dr. Mack, of course, you're defending the idea that replace always or replace most of the time.
I think it's important for everybody to understand that mitral valve regurgitation is not one disease. It's multiple, but specifically two for these purposes. One is primary or degenerative. The other is functional or secondary mitral regurgitation. Mitral valve repair is virtually always the answer for primary or degenerative. However, there is a significant role for replacement in secondary or functional mitral regurgitation. The CTSN trials, sponsored by NHLBI, randomized patients between repair or replacement, and they found no difference in mortality, survival, outcomes, or the primary endpoint of the trial, which was left ventricular end systolic volume index. So in other words, no remodeling advantage to either arm of that. However, what it did find is that the regurgitation, the recurrence of mitral regurgitation was higher in the repair arm, 32% as opposed to 2% with replacement. So, and the conclusion of the article is replacement's more durable. Is that the final answer? No. Should everybody be replaced? No. But I think because of primary disease, we have a bias towards repair, and there's certain patients that we know and we can predict, both from this trial and other information, are going to recur with repair, and those patients should undergo replacement.
Dr. Fattouch, a rebuttal?
No, I completely agree with Dr. Mack. So I think
that's not much of a rebuttal. This is Crossfire. You're supposed to argue. You're supposed to argue with Dr. Mack. but an all or none approach is probably not the right answer.
I like this lecture. So yes. I think that this trial is worth first ones. And the result is very important to put the miliar stone for investigation in this field. We know from this trial that replacement is not better than repair. If you can do a good repair, you can have a reverse and left ventricular remodeling, and you can obtain a good results. So we must focus our investigation to individualize which kind of patient who benefit from valve replacement. And I think that if you can use and select better patient for restrictive mitral valve annuloplasty, and if we can add something in leaflet, subannular, and in left ventricular, some techniques to repair with good results, and I think that in more than 85–90% in cases we can obtain a good repair. So on the other hand, I think that replacement is not a cream. Maybe still a good choice for patients with poor left ventricular function and poor prognosis.
Final words, Dr. Mack.
So as usual in any debate, the positions we take start polarized and we end up not too far apart from one another.
Sure.
And I think that, first of all, regarding replacement, it needs to be a valve-sparing replacement, so there's no disconnection of the ventricle from the annulus. Secondly, those patients that we know are likely to reoccur, as Dr. Fattouch has mentioned, is the patients with severe tethering of the leaflet. And there's multiple ways of measuring that, from anterior and posterior leaflet angles, from tenting height to tenting area, to left ventricular end diastolic dimension. If you get a good repair and it does not recur, you do get positive left ventricular remodeling better than replacement. So the key is focusing on those patients. Now, what Dr. Fattouch has added is that mitral valve repair in functional MR is not just an undersized annuloplasty. There are a lot of additional techniques in addition to that that allow a higher successful repair rate. But I think for the general cardiologists and surgeons out there, probably about half to 2/3 of patients that with functional MR that are undergoing surgery should undergo repair, and the remaining who are likely to recur, replacement.
Good. Well, it sounds like we've reached a little bit of consensus.
Yes.
Thanks for both of you for joining us today on Crossfire, and thanks to all of you for joining us here live from TCT 2015 and Crossfire.